delivered to the consumer. So today is a great start for that conversation. And I'm going to move now to invite our first speaker, who really needs no introduction, Paul Glasziou from Bond University, who's been presenting on the role of health professionals and consumers in reducing overdiagnosis and overtreatment. Paul, I'm going to invite you now to take us through your 10 minutes on the roles of health professionals and consumers in value-based healthcare.
And I might mention before Paul starts, all the bios for all the speakers, especially the PCHSS speakers, are either on the web or on our website.
Fantastic.
Yeah. Great. Well, thank you, Annette and Jeffrey, for the introduction. Yeah. So as you said, I'm going to talk about reducing overdiagnosis and overtreatment. I've just got 10 minutes. So I'm just going to focus particularly on cancer as an example, but I'll mention at the end some of the non-cancer things. But cancer illustrates it. And I thought, just to make it concrete, because I know we've got quite a few new people to the sustainability problem online, I thought I'd give you just a case. This is a real case. You can go to this blog by Andrew here, who at the age of 45 was getting his pilot's license renewed and had an exam that found his PSA, the prostate specific antigen, was 6.3. and a biopsy showed prostate cancer, Gleason stage 6. The urologist said, you have prostate cancer and you'll be dead in 3 years if you do not have it out immediately, and I can fit you in next Thursday. That was 21 years ago. He refused to have treatment, chose monitoring, and his PSA rose steadily as it does with age. And so at 66, he's had no treatment and he's still in good health. Now, I'm using that because we often hear about people whose lives are saved by screening programs, but I think this is a nice illustration of someone whose life would have been damaged if he'd gone on to have prostatectomy and all the complications of prostatectomy by his incidentally and inappropriately done PSA at the age of 45. But the question is, how common is Andrew? How many men are like Andrew? And so we've been puzzling to try and work that out. There have been a number of techniques to do this, but most of them required controlled trials. And so we've been looking at, could we do a population equivalent of that? So a couple of years ago, we developed a new method based on lifetime risk. So the complicated graph of that is here, which I'll just briefly walk you to. This is the lifetime risk of the diagnosis. The green line is the absolute lifetime risk, but the red line is the adjusted one. We have to adjust it because we've been living longer, which gives you a greater chance of developing any form of cancer, in fact, and presenting with that. So this is the fairer comparison. So we compared the lifetime risk in that adjusted 1982 population with the 2012. And what you find is that the excess cancers, the lifetime risk has almost doubled during that period, mostly after the introduction of PSA. So that's what's caused this this increase. There was some use of PSA and digital methods of rectal examination, for example, that probably caused this early blip, but this is the major one, is where PSA comes in here. And so that's about 8,000 men per year, many of them having surgery. And as Annette said, I'm mostly concerned about their outcomes, but actually there's a substantial cost to this as well. And that's goes beyond the cost of the surgery. There's all sorts of support that goes on afterwards. So why does that occur? Just conceptually, one nice thing, graph of this based on a work by Gil Welsh, who's been a leader in this area in the US from Dartmouth. He uses this animal analogy, that there's these fast hummingbirds that you don't catch with screening. There's the slow bears that these are the ones you want to catch, the ones that would have presented with cancer, but you've caught them early enough that treatment makes a difference. Then there are the very slow tortoises, and finally there are the non-progressive snails, and these are the ones where overdiagnosis might occur. And that's a particular problem for prostate cancer. It's true of all cancers, but particularly true of prostate cancer because of the proportion of men who develop something that looks like prostate cancer if they had an autopsy. I don't recommend having an autopsy, but if you have to have one, this is what will happen. So men that are slightly older than me, about 50% of them, if you cut up their prostates, would actually have what the histologist might call prostate cancer detectable at autopsy. So there's a tremendous pool there of detectable supposed cancers, that most of which will not disturb the person in their lifetime, as we saw with that lifetime risk chart. So what can we do about that? I'm talking from both the patient and the doctor's perspective. One thing we can do is inform patients of both the risks and the benefits of getting their PSA done and what age it should be done, etc. The College of GPs has produced a nice 2-page summary sheet of this, and it's one of the most used sheets from the College of GPs that Lyndall Trevena and I helped to develop a few years ago. There's a new version coming out soon, but it illustrates with these so-called icon arrays what the benefits and harms are of overdiagnosis and the small possibility that you may avoid dying from prostate cancer, the sort of 1 in 10,000 over, sorry, 1 in 1,000 over a 13-year period. And we're also doing a project at the moment on using delayed PSAs. When a man wants a PSA, say, here's the information, but I'd like you to think about that before you go and get your PSA done. I'll give you the pathology form. What else could we do? Even when men like Andrew have been detected, the other thing you could do is to, at that stage, have a decision aid for low-grade cases. In Australia, it's becoming more common, fortunately, that these low-grade cases undergo watchful waiting, but still many men are never even made aware, like Andrew, that that's a possibility, that that's an option, that they could just wait and see. Of course, the high-grade and extensive tumours need to be treated straight away, but these low-grade ones, as we saw in the case of Andrew, may just be dormant for a long time, and we can monitor those over time. And finally, so that's what patients and GPs could do, and that might be characterised as shared decision-making in both cases, either in the decision to get a test or the decision to get treatment. The other thing that we could do is policy changes. So, for example, there are various restrictions coming in on the PSA testing on the MBS that would be funded, one changing the interval from 1 to 2 years. And some of these changes will reduce the number of men that get overdiagnosed, which is a good thing. We've also been interested in how much this occurs across all cancers. So we applied that cumulative lifetime risk method using the adjustment to all cancers in Australia and published that last year. And what that showed was about 18% of all cancers in women and 24% of all cancers in men were of the overdiagnosed type. That is, that there was an excess cumulative lifetime risk. And for women, that was in thyroid, renal, melanoma and breast. And for men, that was in thyroid, renal, melanoma and prostate. So it's breast for the excess ones are breast for women and prostate for men. I mentioned that this unavoidable versus avoidable. Some of these overdiagnoses are unavoidable. So, for example, if you're going to run a mammographic screening program, you can try and minimise the numbers that get overdiagnosed, but it's possible to completely avoid it. But there are techniques that we could use to try and reduce that. And for inappropriate screening, and I'd probably class PSA as one of those, you could avoid it completely. And probably for thyroid cancer, you could cut it down. But intervening with these is actually difficult. I mentioned the PSA things that we could do. Lung cancer is less susceptible because there's less of a pool, but you could, we put in a submission about the numbers that could get overdiagnosed and ways that you could minimise that. And thyroid cancer is complex because there are a lot of pathways, but one thing you can do is just stop people doing ultrasounds of the thyroid when they're doing ultrasounds of the carotid artery. I just wanted to finish by saying I've talked about cancer because it's such a good illustration, but we've also been looking at non-cancer overdiagnosis, and that's quite vast as well. Some examples would be ADHD, which I'm sure you're all aware of. Gestational diabetes is an interesting one because a change in the process doubled the number of women being diagnosed. And a recent large trial conducted by Kaiser Permanente in the US showed that that doubling actually led to no improvement in the clinical outcomes for women. So they were being diagnosed, but getting no outcome benefit out of that, as well as costing the system more. But my main concern has been the distress that it causes women to be diagnosed with gestational diabetes when it doesn't make a difference. Low testosterone, subclinical hypothyroidism, we're treating with thyroxine, has no effect, chronic kidney disease. And this cryptic line at the bottom is just to say this is all part of a spectrum. Down this end here, this is the overdiagnosed end where you're getting no benefit from being diagnosed with that condition. But it's actually a spectrum where in the middle here, you've got a lot of cases that are either very low risk or very mild illness, where I think it's a toss-up decision about being treated. So it's not inappropriate to diagnose, but you need a shared decision-making process in order to know whether to treat. And just to finish, to say this is part of the sources of healthcare waste that we've been looking at. And this is work from the United States, where Berwick showed that overtreatment was a major component of waste. But the thing that he didn't look at was that he didn't consider overdiagnosis. So people who are overdiagnosed but treated, he wouldn't have considered as being inappropriately treated. And I'll finish there. Thank you, Annette. I'll hand back to you.
Thanks, Paul. The work that you've been doing with your group at Bonds has been absolutely fantastic, and it's been the most outstanding of the work that we've been able to do. So thank you for that. We're not going to have questions now. We're going to hold them to the end of the session. So make sure you keep notes. The next presenter is again a group who've been among the most prolific in terms of the work that they've been doing for the centre. Tony Scott from Melbourne University. Tony's going to present on incentivising value-based care through payment models. An extremely important tool or lever in moving the system to where we want it to go. So over to you, Tony.